Great. And start the recording too. Yeah, there we are, have that. So, welcome to the meeting. It's in Block 1, Floor 2, County Hall. It's 1 o'clock, and this is the Health and Wellbeing Overview and Scrutiny. Welcome all. The first item on the agenda is apologies for absence.
I haven't received any, Chair.
I've received them from Councillor Homer. Okay, the next thing is the minutes of the previous meeting, the 26th of July and the 2nd of August. I agree that I sign them as a true record.
Agreed.
Thank you. Disclosure of members' interests is the next thing on the agenda. You don't need to disclose anything that you've previously disclosed in the documents that you signed earlier. So there aren't any. No, it doesn't look like it. So the next thing is the forward plan. Chris, do you want to speak to this?
Just to say that the forward plan is there for members to note, really. There isn't anything on there at the moment, particularly for this committee.
Excellent, thanks for that. So the next thing on the agenda is item 5, which is the COVID update, public health CCG, and I believe Liz Morgan is doing this.
Yes.
Excellent, well, carry on. Thank you.
Thank you very much. Okay, so firstly then, this looks at what's going on between different regions across the country, well, across England, and there is quite a differing picture depending on where you live. So if you look at that dark red line, which is the southwest, you can see that cases have really spiked down there, and we think that a lot of that is attributable to some of the festivals that they've had down in the southwest. In London, cases are falling, and in the northwest and the northeast, they're sort of gradually going up. This is the what the LA7 picture is looking like, and you can see that actually most of the local authorities are looking pretty similar, but some of them are going up slightly. So we've had a slight increase over the last couple of weeks. Newcastle is still going down, and I expect we can see that those case rates will come to some sort of equilibrium over the next few weeks, all things being equal. What we do know from some of the ONS prevalence studies is that the amount of infection in the community, so that's not just people who've been tested, but the prevalence of infection, so that's the number of people in communities who have infection at any one time, that has been increasing over the last few weeks. So the most recent data tells us that about 1 in 70 people are infected at any one time, and that's the most recent data up to the 20th of August. It's slightly lower in the northeast than in other places. And this is the most recent data for Northumberland. As I said, we had seen cases start to increase over the last sort of week or 10 days. That seems to have levelled off. Difficult really to know what's going to happen over the next few weeks, because there are many things that influence changes in case rates. But what has been consistent is the high case rates in younger people. But we have seen increases in case rates across almost every age group. So the things that change case rates are obviously where we are in the roadmap. So we're obviously at a situation now where everything is largely open, but actually even within that we're seeing that some businesses who retained quite high levels of mitigation, that over a period of time those are becoming more relaxed. The other things that influence the case rates are the extent to which people return to pre-COVID behaviours. So all the modelling suggests that the quicker our population returns to those pre-COVID behaviours, so things like restricting the numbers of social contacts, wearing face coverings, socialising indoors, or actually we'd prefer people to socialise outdoors, and the extent to which they sort of stop maintaining good respiratory hygiene and hand washing, that will all influence case rates and will largely increase them if we don't maintain those behaviours. Of course, the thing that we've got in our favour is the vaccination programme, and we'll hear more detail about that later. But of course, we do still have quite a large pool of people who are unvaccinated. So, you know, most children are unvaccinated, and there are a whole cohort of people who haven't had the vaccination for whatever reason, or who have perhaps not responded quite as well as we would have liked. And of course, what we're seeing is that in those people who were vaccinated early, so particularly those people who were vaccinated right at the beginning of the programme, that we're seeing immunity starting to wane, and of course that will mean that they are more susceptible to infection. Testing behaviour also influences the number of cases that are being diagnosed, and we've seen testing reduce since schools closed, and that's probably partly because people don't want to get tested because they don't want to come back as positive when they've just organised a holiday. And then the other thing that is going to have a real influence is the schools opening next week. What we've seen in Scotland is a very rapid rise in case rates since the middle of August when schools opened. And the reason why high case rates are a concern nationally is firstly because of long COVID. So again, the most recent data suggests that about 945,000 people have got long COVID. So that's symptoms of COVID 4 weeks after they became infected. And obviously that has an impact socially and economically. We know that admissions are increasing nationally, although they're staying pretty steady locally during August. And of course, those admissions, or increasing admissions, and high numbers of people, relatively high numbers of people in hospital with COVID, are on the back of an NHS which is already under quite a bit of pressure. And we can also see that deaths are very slowly increasing. We don't really have a huge amount of detail about what sits behind that, but we're also seeing that locally. So whereas we only had one death from early April until the end of June, we had 16 deaths in August. So from a COVID vaccination point of view, I think Richard's here, thank goodness. I won't dwell on this too much because Richard is going to talk about this in a bit more detail, but it does continue to be an extremely complex but very successful vaccination programme. So Richard will give you more detail about that later. I think the important thing to think about is sort of winter planning and resilience, and prevention really is the best form of defence for us over the next few months, because I think we're anticipating quite a tricky winter for a number of reasons. So really important this year to achieve high uptake rates for the flu vaccine. We need to keep promoting the COVID vaccine, so not just the first dose, but all the second dose and the booster doses for those people who are going to be called forward. We've done a lot of work around interventions to address vaccine inequalities, and we just need to make sure that when we introduce the booster programme and for the flu programme as well, that we introduce all those interventions to ensure that all of our communities have equal access to the vaccine, that nobody gets left behind. And also really important that we maintain support for care settings and care providers, both in terms of vaccination, but also in terms of supporting compliance with infection prevention and control measures and outbreak management. Obviously, the COVID vaccine will become mandatory from the 11th of November for a large proportion of care homes. So those care homes that provide nursing and personal care will be required, all of their staff will be required to have had the COVID vaccine. I think we're not sure what the impact of that is going to be locally, but I understand that there hasn't been too many care homes that have highlighted that as an issue for them. But the social care workforce is quite fragile, so we just need to make sure that we maintain sort of close conversations with our care providers and care settings. And then at the moment we have already got high levels of respiratory virus, the sort of respiratory viruses that we wouldn't normally see during this time of year. So RSV, which is a respiratory virus which is quite common in children, is at the sort of levels that we normally see over the winter. So we need to make sure that we give the right advice to nurseries, childminders and educational settings, not just on COVID, but on managing respiratory illness and outbreaks in general. Really important that we signpost people to the right source of advice for minor illness, because actually if you don't need to go and call your GP, there are other sources of advice for you. You can go to your community pharmacy and call NHS direct. So lots of alternative sources of advice. And then there is still something about maintaining those COVID prevention behaviours which have been really successful. So the reason why we had no flu cases last year was because of all the hand washing, the face covering, wearing, the not having lots of contacts with other people, and staying in well ventilated areas. So we just need to keep all of that up, and obviously communications are going to be absolutely critical over the next few months. So really the key messages are the same as they have been for some time now, and that's be cautious, be considerate and be kind. So we need to maintain all of those behaviours that we know prevent infection. Make sure that enclosed spaces are really well ventilated. Get tested if you feel as though you have any of those symptoms associated with coronavirus, and obviously take up the vaccination offer where you can. And from a considerate point of view, I think it's really important that we continue to wear face coverings in indoor areas, particularly on public transport, because although at an individual level they may not make much difference, at a population level they certainly do. And also be kind to other people, because we know that there are lots of people out in our communities who are really nervous about going out and about in the public, particularly about using public transport. And we just still need to just be conscious that other people will want to maintain that social distance and continue to wear face coverings. So I'll hand over to Richard now, who's, if somebody knows where the presentation is, to talk about the vaccination programme in more detail.
Yeah, that's the last slide. If we can go back to just to the top. Perfect. Is somebody able to do a next slide, please, for us as well, or is there a clicker? Thank you, Liz. So to talk you through the latest position on the vaccination programme. So to date, we have vaccinated 90% of residents with a first dose and 84.1% of residents with a second dose. That equates to 246,692 first doses and just over 230,000 second doses. Northumberland now has the highest percentage uptake of both doses of the vaccine of any upper tier local authority area in England. So that's a fantastic position for us to be in terms of protection for our residents. And in total, we've administered 477,319 vaccines to date. Next slide, please, Liz. In terms of the uptake of first doses then across age bands, the slide there just shows in 5-year intervals what the uptake is for first doses. So the lowest figure we have there is 76.6%, which is the 25 to 29-year-old cohort. But broadly speaking, we've got over 75% uptake within each and every one of those cohorts. Liz, if you pop on to the next slide, please. And within second doses, we've made some really good progress on this since I last presented to Health and Wellbeing Board, with the bringing forward of second doses to 8 weeks for all cohorts. We've now got over 75% uptake of second doses across all age bands as well. Again, the lowest age band here is the 25 to 29-year-olds, but we've seen really strong uptake across all of those age bands. Liz just mentioned before those who were unvaccinated. So just to give you an idea of the number of people we've got in the county who haven't received a first dose of the vaccine, we've got just over 15,000 over 18s who've yet to receive a first dose. And of those, just under 6,000 of them are over 50. So those that we'd consider to be most vulnerable from COVID. So there is a reasonably significant portion of the residents who haven't been vaccinated yet for whatever reason. Next slide, please. Liz mentioned the work of the Vaccine Equity Board. That was a joint group established between the CCG and public health colleagues, with representation from lots of other agencies, and through the work of the Vaccine Equity Board we've identified and addressed potential areas of inequity within the vaccination rollout. Our priorities initially for that group were Black, Asian and minority ethnic groups, especially our Black communities, those from a Gypsy and Roma traveller community, those registered as having a learning disability or severe mental illness, and also areas of socioeconomic deprivation. And we also, as you would imagine, for a county like Northumberland, considered things like rurality and travel time as key considerations in terms of equity of access as well. Linked to that, there is a regional Vaccine Equity Board, which Liz sits on our behalf, and alongside that, a regional comms group, which has been established to tackle vaccine hesitancy, vaccine confidence, and there's a really robust comms programme and campaign linked to that. And the intention for a lot of the work of the Vaccine Equity Board and the areas of inequity that we identify is for our PCN-led roving vaccine unit to target some of those harder to reach groups. Next slide, please, Liz. So in terms of the ways we've gone about improving and promoting uptake, where we've identified areas and addressed low uptake, we've made sure that we've got a number of different things in place so patients can access the vaccine more readily. So a number of PCN and community pharmacy sites are now offering walk-in vaccinations, especially in our areas of highest deprivation across Blyth and Ashington. We've worked jointly with the maternity team at Northumbria Healthcare to provide midwifery advice. So not so long ago there was a concern around increased admissions in pregnant women who hadn't been vaccinated. So what we've done is team up with maternity colleagues to provide midwifery support at vaccination clinics. And each and every one of the unvaccinated expectant mothers we've got at those clinics has been contacted, invited to come in and have a conversation with the midwife, because the evidence has suggested that it's those one-to-one conversations about any concerns that expectant mothers might have that really does increase uptake. And we've seen already some really positive numbers in terms of those expectant mothers getting vaccinated. We've also worked to provide pop-up vaccinations at large gatherings now that a lot of the restrictions have started to fall back. So just this weekend, we had the vaccination bus was at the Northumberland Pride Festival offering walk-in vaccinations there. And we also had a stand within the health zone there to promote uptake of the vaccine and answer any questions residents might have. And we're also continuing, as I said, to promote vaccination, not just locally but regionally, as part of the Beat COVID North East campaign. And a phrase that you'll probably hear a lot as we go into phase 3 is that an evergreen offer will remain open to all eligible patients for a first and second dose of the COVID vaccine. So if they haven't had it before we get to the booster programme, that's absolutely fine. They can still come forward and get a first dose at any point. Next slide, please. Just to cover the work of the roving vaccine unit, because this has been one of the biggest successes of our programme in Northumberland. It's PCN-led, so it's led by a GP practice in Cramlington, but is able to work across the whole county. It was initially commissioned to target our harder-to-reach groups and ensure local provision in West Northumberland, when that PCN opted out of phase 2 of the programme. But since then, and that initial launch in Bellingham, we've seen the vaccine unit go, far and wide across not just our county, but the whole of the North East region, and has provided a lot of fantastic support to areas that have had a lot lower uptake than Northumberland's had. So the van's been in Newcastle, across Tees Valley at Darlington's Pride Festival, and a number of sites in Hartlepool, and also assisted in North Tyneside when we had the initial surge in the Delta variant there. So although it's our Northumberland vaccine unit, it's been to the benefit of the whole region, and actually the COVID response centre based out of Newcastle Hospitals are now looking at commissioning a very similar model that will be available to the whole region to book and learning from a lot of the things that we've done with our vaccine unit in Northumberland. Next slide, please. In terms of vaccinating children and young people, this is a relatively new development in the vaccination programme, and the latest JCVI guidance that we had to government was that all 16 and 17-year-olds, and then those most vulnerable 12 to 15-year-olds, were to be vaccinated. It's just one dose at the moment for those 16 and 17-year-olds, whereas the eligible 12 to 15-year-olds will get 2 doses. And we've moved very quickly across our primary care networks to identify all of the eligible 12 to 15-year-olds and make sure they're proactively contacted and invited in to be vaccinated. And the 16 to 17-year-olds have all received a national letter inviting them to attend a vaccination clinic, so they can attend either walk-in or pop-up clinics, which we're promoting via the CCG social media website, and Council and Northumbria Healthcare colleagues are also sharing them, or they can also attend pre-book clinics if their PCN gets in touch with them. We've also seen through the links we have on the Health Protection Board in Northumberland a number of schools and colleges that have arranged for pop-up clinics delivered by either the local PCN or the roving vaccine unit to come to their site and deliver vaccinations for their students before they go back. And we're still awaiting JCVI's opinion and advice on vaccination of the entire 12 to 15-year-old cohort. That's something we've seen done elsewhere in the world, so the States have done it, Portugal and Germany have also made that move. Not to preempt anything JCVI are going to do, but we are anticipating advice on that imminently. And going forward, the uptake of vaccination in children and young people will be monitored by the Health Protection Board in the same way we have done with the rest of the programme. And we'll also look at areas of inequity within that vaccination of young people as well. Next slide, please, Liz. In terms of phase 3 of the vaccination programme then, there's not a great deal more to say on this than the last update I gave at Health and Wellbeing Board, which is that the JCVI's interim advice still stands. They initially told us that any potential booster programme should look to begin on the 6th of September. Obviously, that's not very far away when we're sat here on the 31st of August, and we're still awaiting final JCVI guidance on whether that booster programme will A, go ahead, B, which cohorts it will target, and C, which vaccine we will use. The reason we haven't had that advice yet is due to a number of clinical trials that are ongoing that need to report and submit their findings to JCVI, which will then enable them to advise on things like whether the COVID booster can be co-administered with the flu vaccine, what the best type of vaccine is to use for that booster programme, and which order we should look to do people in. In terms of the plans we have in place locally, it's fair to say we are really well prepared for this. We've got all of our PCN sites set up and ready to go effectively from next Monday if they need to. We've also got a couple of new PCN sites where we've looked to add some additional provision that we didn't have first time round. We have a number of additional community pharmacy sites identified to come online as part of phase 3, and the hospital hub at Northumbria Healthcare will also be restarting to vaccinate healthcare workers. So we're in a really good position and just waiting for that final guidance really from JCVI to give us the go-ahead. So we're hoping we'll get that this week and we can get started on the booster programme, but whenever that comes, we'll be ready to start. Next slide, please, Liz. So just to reflect on why we've been so successful in Northumberland and why we've got that best uptake of 2 doses in the country. A lot of it's down to the incredible engagement we've had from teams of highly motivated and dedicated health and social care workers, the central coordination by the CCG with joint leadership between ourselves and the local authority. We've got a joint director post that's led the vaccination programme, has really helped in terms of leveraging some of those benefits of joint working we can get. The PCNs have collaborated fantastically for relatively immature organisations. They've worked brilliantly across not just practice boundaries, but locality boundaries as well to deliver a really comprehensive service. We've had very strong system leadership in our ICS footprint by the System Vaccination Operations Centre that's led by Newcastle Hospitals, and we've been able to foster a really good relationship with them between our CCG and SVOC, which has helped. Really effective communication, Liz mentioned when she was talking before, that's been a huge benefit to our programme, and I think we've communicated really well with patients and stakeholders. Things like the Listen to Liz, videos that we did, and we've done a lot of sort of Q&A videos from the CCG as well that have been shared by HealthWatch colleagues, so we've really done our best to try and communicate directly with patients on the benefits of vaccination. As you would imagine, in Northumberland, we've built on the already really good links we have in terms of integration and cooperation, and work really closely across the CCG, primary care, public health, local authority, lots of other stakeholders, including the voluntary sector, to come together and make sure that there's a really comprehensive offer to residents, which has included things like free transport provided by Age UK to vaccination clinics if patients had trouble with transport. And also, I think the public support that we've seen for the vaccination programme, their confidence in it and their engagement with it has been really excellent, and is testament to the people of Northumberland that they've all come forward to be vaccinated so readily. Next slide, please. Just to touch on the challenges, obviously with a vaccination programme of this size, there were always going to be really big challenges. The National Command and Control has left our local teams with all the burden of responsibility to deliver the programme, but very little control over how they go about doing that. We've seen several course corrections and changes in guidance, often at very short notice, and normally in the media first, and I dare say that will happen again with the impending guidance from JCVI for phase 3. And we've also had a really, again, as you'd imagine, with a huge global vaccination effort, a very unpredictable supply chain, and a kind of push model of deliveries initially, a kind of get-what-you're-given approach, which made it really difficult for PCNs to deal with. However, having said that, going forward, we now have a lot more flexibility over how we use the Pfizer vaccine. There's not that 3.5-day limit on being able to keep it out of the fridge for, and we've got a lot more flexibility in terms of how we'll be able to deliver phase 3, so that should stand us in good stead. As I've mentioned above, some of the nationally mandated decisions have not always reflected the need for local interpretation and flexibility, so we've had to think quickly and be agile in Northumberland to make sure that we can come up with solutions where the national position doesn't necessarily help us. The multiple routes to access vaccinations have been confusing, I think, for patients at times, and caused a bit of frustration for providers. So the difference mainly between the national booking service and local call and recall, that's something we've done a lot of comms on to try and combat that confusion for patients. And I think on the whole we've done a reasonably good job with that, but that's something we'll need to be very mindful of as we go into phase 3, to make sure that when patients are called forward, they understand where it is they're being called from and where they're going to. And finally, just the sheer size and scale of the programme. We've vaccinated just about everybody in the county once, almost twice, and now we're going to have to do the vast majority of those people again. So it's been a huge effort and undertaking, at the same time as having to deliver all of the rigours of routine healthcare and general practice. Next slide, please, Liz. So just finally, to summarise the next steps for the programme, we're going to continue to provide second doses to all eligible patients at 8 weeks and get that second dose percentage even higher and even closer to that 90% of first doses that we've got. We'll continue to promote the importance of that second dose uptake to provide the greatest possible protection to patients and reduce opportunities for transmission of the virus. We'll continue to maximise uptake across all of the priority groups, so that's young people, but also those adults who've previously refused. We'll increase our activity and promotion of the benefits of vaccination in some of our most deprived communities to continue to tackle inequity and continue to identify groups like those unvaccinated pregnant mothers that I talked about. The Evergreen offer will absolutely stay in place throughout the autumn and winter, and we'll continue to collaborate and cooperate across all of those delivery models and stakeholders that we've had. And I think most importantly, to continue to communicate proactively and effectively with our patients and public to remind them of the importance of the flu vaccine and the importance of the booster vaccine. I think there is a risk potentially of a little bit of sort of vaccine fatigue for people thinking, oh, do I really need to get this other one, or is the flu as important as the COVID booster? Absolutely. We want as many people as possible to get all of those immunisations, and our aim is to make sure they've got access to that as locally as possible, as easily as possible, and hopefully both at the same time, pending advice from JCVI, but that'll make things a lot more efficient for us in terms of providing both jabs to patients. So yeah, happy to take any questions from members on any of that.
Excellent. Thank you very much. Very reassuring. Well, I'm reassured anyway. Councillor Dodd.
She doesn't need it. Right, I have a number of questions, but it all stems down to the last 10%. This number that we're saying is, what do you think, it was 15,000 and whatever. We're boiling down to the last 10% of 10,000 people. And that number is remaining static. I appreciate you trying everything possible, but this stubborn 10% might muck it up for the rest of us. At what point do we say that because you refuse to have a vaccine, you can't work in certain areas, or you can't do this, or you can't travel there, or you can't, because that might be the only weapon that's left in the box. Now, then there might be someone sitting here who's refused to have a vaccine, I don't know. We might have all refused. I've had a vaccine twice, and I'm looking forward if I've got to have a booster, because I don't want to end up like these people, and we see it every day. Someone who's like being a big anti-vaxxer, I think there was one at the weekend who got it and now sadly died. And, you know, I don't know if anybody here is on Facebook, I presume you all are, but some of the rubbish that comes out of Facebook is unbelievable by some of these people who, I don't know where they get their information. We know that people are being targeted through religious groups, through black, minority, ethnics, etc. When is the point? Because if we're sitting here in, say, 6 months' time and that number really hasn't changed, we're going to have to do something about it as a council. Because the schools are opening up in the next week, the universities are open, and if spikes continue, we're going to be in this sort of state of limbo for decades. And I, for one, would want to get out of this. And two, you know, a minority that are easily led or whatever seem to hold the key to this. And I wonder, you know, at some point we will have to discuss this. We have, I'm not sure the numbers of staff we have in this organisation now, but it is substantial. We're probably the biggest employer in this county, or one of them, and we will have to make a decision on whether people work in old folks' homes, children's looked after children, schools, you name it, or in a care situation. That decision somewhere is coming where we're going to have to say, that's enough, mate. Can anybody answer that? And I know it's a very...
I don't think, Richard, anyone can.
I know you're right.
I can certainly ask, if I was officers, I wouldn't want to comment on the curtailment of civil liberties. I don't think it's anything that this committee can ask for. Well, they can ask for it, but there's nothing we can do about it. It'll be central government that decides these sort of things, not us. And if Liz Morgan seems to want to grab the tiger by the tail, so I shall let her have a go.
So I think the first thing is that vaccination is going to become mandatory for some sectors of the community. So, as I said earlier, some staff working in some care settings, and actually a vast majority of the people visiting those care settings will be required to be vaccinated. They need to have their first vaccine by the 11th of November. So I think this is probably the first time that we've actually made vaccination mandatory in this country. But I think there's lots of other things that we can do. And actually we are sort of slowly chipping away at all of those people who haven't had their vaccine. And I think, you know, the number of people who flatly refuse to have it are relatively small. I think there is something about, you know, just continuing to work as hard as we can to make the vaccine as accessible as possible. So I think a couple of other things that we can do is use that making every contact count concept to promote the vaccine at every opportunity, because even if only 1 in 100 conversation stimulates somebody to have a vaccine, then that's definitely worth doing. We've done a lot of work through employers to encourage them to allow staff to have time off to have the vaccine. Talked about how that's going to be beneficial for them as an employer in terms of maintaining resilience and reducing time off. So I think we just need to keep chipping away. But of course there is a significant proportion of the population who are never going to be offered the vaccine. So, you know, even if we offer vaccines to all 12 to 15-year-olds, there's still going to be hundreds of thousands of children under the age of 12 who don't get the vaccine.
Did you wish to come back, Richard, or?
Well, I think it's a conversation that we're going to have at some point to say we are the biggest employer. We employ people to look after the vulnerable people, etc. I don't know where the records come, whether I mean, there's a lot of people in my generation who've got a pock mark on their arm. you know, from when they were a child, when I can't remember what it was for, but it was for something.
It was a BCG, Richard. It was for a lot of things.
Was it?
It was.
I remember a big six spike thing that went bang
Yeah,
into your arm. We don't get that anymore. Why? Because it worked. And that was probably, I mean, if the internet and Facebook had been around then, it probably would have had the same reaction as it has now. And we all know it's the same people at the same time. So at some point, we're going to have an awkward conversation with the electorate or staff or people like that. And I just hope we're prepared, because there'll be a whole lot of lawyers sitting waiting to say, oh, you can't do that. And
There
you
will
said
be.
the word civil liberties. I've got a civil liberty, and that's to live. So,
Well, let's hope all the lawyers are vaccinated, Richard. I've got Councillor Hunter, Councillor Nesbitt, then Councillor Hill.
Thank you, Chair. It's more on to do with this winter, because it's heavily advertised on the TV at the minute that we're looking for a bad winter because they're expecting flu and that to take forward. So it's more to the fact that, yes, you're saying you're ready to go, so that if we get word next week, can we sort of quickly get the programme started for the elderly and the vulnerable, because they were the first ones that got the COVID, to try and get the flu vaccine and the COVID booster up and running, because they are starting to get worried as to the factors they're now coming to be at risk again, where they were good at coming forward the first time.
Yeah, so I think historically we've had very strong uptake of flu vaccinations in Northumberland. We're always top of the pile within the region. So I think there's nothing to suggest we'll not be able to do that again. And we're hoping actually to be able to increase our flu numbers off the back of the really successful COVID vaccination programme. There is a Northumberland Vaccine Collaborative that meets regularly with representation from CCG, local authority and lots of other stakeholders that's already got really robust plans in place for delivery of flu. As I mentioned before, ideally we'd love to be able to give it alongside the COVID booster and do people in a sort of 2-for-1 from an efficiency point of view. But if the guidance that comes from government that says we can't do that and we need to give them both separately, you know, we're just as well prepared to be able to do that. So we've got a lot of confidence as a CCG and as a local healthcare system that we'll be able to meet, if not exceed, our uptake figures we've had for flu in the past. And the COVID booster as well. So yeah, I think all we can say at the minute until we get that final advice is that we're as well prepared as possible for that instruction as and when it comes.
Thank you, Chair. That's good news for the local communities in Northumberland.
Thanks, Isabel. Councillor Nesbitt.
Couple of questions from me. First of all, abbreviations, I hate them. SVOC and JCVI.
Sorry, apologies, we do speak a different language in the NHS at times. So SVOC is the System Vaccination Operations Centre. So that's the team predominantly based at Newcastle Hospitals who provide coordination across the North East and North Cumbria ICS footprint for the vaccination programme. And JCVI is the Joint Committee on Vaccines and Immunisation. So that's an independent group of scientists that meet and advise government on the rollout of particular immunisation programmes.
Right, thanks for that. The second one is about the vaccines, because you've got the shingles ongoing, you've got the COVID booster and the flu jab. So are they all going to be given together, or are they going to be given separate?
So the shingles vaccine will continue as normal and separate from the COVID and flu booster programme. We're waiting for advice from the Joint Committee on Vaccine and Immunisation on co-administration and whether we can give flu and COVID at the same time. Their initial indications are that it should be viable, but we're waiting for the outcome of a number of clinical trials that have been looking into this over the last few months to make sure and to advise us for definite whether we can co-administer or not. Previously, when we first started the COVID campaign back in December of last year, there had to be at least 7 days between your flu jab and your COVID jab. That position at the moment is still in place until we get advised any differently, but we are hopeful that co-administration will be possible. It just depends on that independent group of scientists giving us the go-ahead.
And thirdly, sorry, I should have said 3. And the COVID booster, is it right what they're saying though, if you've had the Pfizer, you're going to have the opposite one to that one for the booster?
Not necessarily. Again, we're awaiting guidance from JCVI on which vaccine it will be that we use. The understanding at the moment is that it will most likely be the Pfizer vaccine, but we're awaiting definite confirmation of that. So there's no guarantee if you got AZ first time round, you'll get the alternate, and if you got Pfizer, you'll get AZ. We're waiting on clarity, and people will be offered and given what we're advised to give them.
Thanks for that. And can I just see, is they're doing a fantastic job here, getting things done. Liz, especially Liz Morgan's doing a brilliant job on things. Thank you.
Thanks for that. Councillor Hill?
Thank you. I've got a question on the stats and a general question. I'll ask them together because they kind of link in. Obviously, the rate of hospitalisation is, you will be able to detect every case of time somebody's hospitalised because of COVID. Not necessarily how many people are infected. But is there any sort of up-to-date, educated guesses, stats around what the current hospitalisation rate is per infection rate and how it, how it compares to before the time the vaccine, major rollout of the vaccine, and obviously particularly rates of hospitalisation for those vaccinated and those not? Because I think that'd be a really useful stat, and it would help drum home the importance, if that's the case we made, of getting vaccinated. Linked into that, what is the general discussion behind the scenes? I've maybe asked what's going on behind the scenes. You maybe can't say too much, but is there any indication that there might be a move away from what they're talking about living with COVID? And is the L word being mentioned? Is the lockdown word being potentially mentioned for this winter? Because if it is, then there would be the suggestion that and this links back to my first question, that the vaccination isn't as, it's effective, it's worth getting, but it's not as effective as we would have hoped, because I see there's a change of language. Before it was talked about, if we get a vaccination, then wonderful news that we did, this is a game changer. The wording is now, it's preventing serious COVID. So it sounds almost like, why you should wear a seatbelt in a car. It can prevent serious, it could save your life, but there's, it's not going to prevent you from a car crash, and it's not going to prevent some deaths. So it's a question around the evidence stats around what's happening with the infection to hospitalisation rate now, with those vaccinated, those not vaccinated. And is there any talk about potential of a lockdown or more severe restrictions this winter?
So when we look at the number of people who are being hospitalised now, with the rates that we've got now, compared to the number of people hospitalised at the beginning of the year, there's just no comparison. So there's no argument at all that the vaccination programme has had a massive impact on hospital admissions. So the current estimates are that the vaccination programme has reduced nearly 25 million infections, 82,000 admissions, and up to 109,500 deaths. So it has had a significant impact, but the vaccine, the trials looked at the ability of the vaccine to prevent serious infection and death. The vaccines were never designed, it's not a sterilising vaccine, so it won't necessarily prevent you from becoming infected, but it might prevent you from developing disease. In terms of looking at rate of hospitalisations, with the vaccinated compared to the unvaccinated, I don't have those statistics to hand, but I can certainly try and dig those out for you. And from the point of view of any sort of lockdown, I haven't heard anything about a lockdown. But obviously there is, I think, at the moment, the admissions are sort of manageable, so the impact on the NHS is manageable. But, some sort of mitigations will be required if we get further pressure on the NHS that makes it less manageable. And that may be about, delaying routine operations again. We'd prefer not to go down that route. But no, I haven't heard lockdown mentioned in any shape or form.
Okay, happy with that?
Just a bit of feedback. It is, we've talked about this before, the stats, that the way that they have been quoted all along, so it's been things like how many per 100,000 of the population. It may exist somewhere, but I think it would be really useful and help with, encourage people to get the vaccination. If you said, for example, this might be way off, but, those without a vaccine, there's a 1 in 16 chance of being hospitalisation. If you've got it, it's 1 in 300 or whatever. Those stats are just for the point of to specify it for individuals rather than sometimes these bigger figures, more professional stats. But I think it just helps drive the message home.
Okay, we seem to have the movers in next door, but never mind. Was that all we have for that? It looks as though we do. So we're now on to 6, which is the Northumberland Recovery of General Practice COVID-19 21-22. And who? Hi. If you just press the button, the little red light will come on and the floor is yours.
Lovely, thank you. I'll just, there's a presentation to come up there on the screen. So just by way of introduction, my name's Pamela Phelps. I'm the Senior Head of Commissioning for Primary Care with Northumberland CCG. So I cover the commissioning, contract of general practice and also part of the vaccination and flu programmes in the past and going forward. So what I wanted to do today was give you an update on the recovery of general practice. At present, I think the conversations with flu, COVID vaccines, boosters, we still feel like we're still in the midst of a challenge, which we very much are. But there is also the impetus to make sure patients and residents of Northumberland and the country understand that general practice is very much open for business. And what I wanted to do was just go over with you some of the priority areas that we looked at through the pandemic, and also how, as a CCG, with general practice, we're monitoring the recovery and back to normal as much as that can be. So during the pandemic, obviously, there was NHS England and who contract for general practice nationally would send out updates. They gave us priority areas to focus on, and they also set out the requirements within standard operating procedures as to the expectations for general practice and other health and care settings, as how we managed from last March right through to March and April this year. Now, those changes came about quite reactively. General practice adapted to the priority areas, and they implemented changes as to how patients access the services. And over the last winter, they also then focused the areas of prioritisation on the groups I've got on the screen there. Just going back to the point from Councillor Hill earlier as well, the lockdowns and the demand pre and post lockdowns was very different, and that affected the demand on all health and care services, and especially general practice. So the fluctuations in demand, but also making sure patients knew they could contact services. Obviously, waiting lists were paused, so it did have a significant effect. And that focus and prioritisation of work has been quite over a long period of time, and it still continues to this point. So the prioritisation looked at looking at expanding capacity, and there was a programme of work nationally set for general practice about expansion. Increasing GP capacity, so the focus in Northumberland was part of the work to ensure we could maintain the levels of the workforce where possible. Obviously, the workforce was affected by the pandemic, as in all forms of life, and we did see drops in capacity in general practice because of that. We have seen a significant increase in the number of GPs through a fellowship programme in Northumberland. So over the last year, we've got 10 more GPs working, and those fellows are GPs that have left their training placements, they've completed their training, moved into general practice, and now they've been retained locally and supported through a programme of work to enter the workforce. Oximetry at home, so the respiratory illness and the services that support the long COVID, prioritisation of patients. So these were the areas that general practice focused on in the main. We had clinically extremely vulnerable patients, obviously those who shielded, and they were required to have additional support. Chronic disease management, so patients who probably weren't managing their conditions as well and needed additional input throughout the COVID pandemic and any side effects or issues they would have had. And obviously the routine vaccinations, because what we didn't want to do was focus on a pandemic and have an emerging issue of potentially children or others who weren't being vaccinated. So we needed to maintain those prevention parts of care. Learning disabilities and serious mental illness, so health checks, making sure the health and the care of those patients with significant needs were supported and cared for. I mentioned the workforce earlier. We then had the introduction, obviously, from December of the vaccination programme, which has taken a lot of focus with our networks and practices, but how they've worked together, how they've collaborated to deliver that programme alongside some of those priority areas in core general practice has been significant. The infection prevention control changes and social distancing, so practice has had to go through a lot of work to adapt their premises, and we did a lot of work and investment with them to ensure that we could ensure infection prevention control both in our core general practice sites but also all of the branch sites and services across the rural areas. We did have at some point where we were closing some sites, and we had hot sites where patients with potential COVID infection were directed to. And again, that consolidated the workforce, but it moved people around the system to deal with demand as it arose. And then overall access to primary care through the requirements from the National Standard Operating Procedures. There was a lot of changes digitally to the delivery and access to services. So we saw video consultations introduced. Telephone consultations were much more prevalent, and the face-to-face, as we said, was prioritised around those who clinically, where it was clinically appropriate to do so and manage. So, as a programme of work for recovery of general practice, given the fact we're still vaccinating and we're moving into phase 3 and the flu vaccine programme, we still have some demands from the COVID pandemic. But we are also expecting to see core general practice return to normal. So the priority areas as a CCG, we have asked all general practices to pull together a high-level recovery plan, and that focuses on some key areas. We will monitor progress on some of the key clinical groups of patients and also access face-to-face versus remote consultations. And then we've just kicked off a piece of work around access to general practice specifically and patient engagement. What we're doing there is we're reviewing all of the engagement we've had with patients over the last couple of years about access to general practice. We're working closely with Health Watch. We're considering the digitally disadvantaged, which is easy to say for some, and how the impact and the changes reflect for patients accessing their GPs. So the aim of that piece of work is to fill the gaps on what we don't know about the reactive changes through the pandemic and any future changes to maybe digital options or consolidated sites of practices working together to really capture the views of the patients. Now, we've also had a lot of communication in from elected members and councillors about access to general practice during the COVID to help give clarity and with the comms and the messages for patients. So we want to work through this piece of engagement with elected members and councillors so we can capture those patients who've really felt the impact of these changes, and we can work to better the ways going forward. There's also some access to general practice changes coming from April next year. So we currently have an extended access programme and an extended hours programme. So both of those schemes at the moment are a way of contracting with general practice to ensure 7-day cover, bank holidays, 8 till 8 for primary care. Those contracting requirements will change from April, hopefully for the better. We're still waiting for the guidance to come nationally, but we want to maximise what we do in Northumberland, given the rurality, distance, access and the types of consultation. And the expanding capacity programme I mentioned before, that focused on those long-term conditions patients with serious mental illness, and it provided some investment into general practice to manage the capacity and the workload during the pandemic. So there's a programme of work to monitor, look at the plans and make sure we are resilient enough that we can offer services to patients like we used to pre-pandemic at some point. So the monitoring tactics are, we have sustainability visits regularly with every practice in Northumberland where we can have that open and honest conversation and we can identify areas of support. We have the Improve and Access project, which I mentioned about patient experience and engagement. We will have a set of performance measures that we will put in place. We have baselines ready about GP appointment capture. So there's a new national programme of work where all general practices have had to map their appointments to be captured electronically, and there will be a national capture of that work and a new survey of patients once they make contact with the patient, rather than the previous retrospective patient access survey. We're looking at the uptake of the serious mental illness and LD health checks. We're looking at key areas of chronic disease management and monitoring the progress and performance of practices in each of those areas. And also we have the oximetry at home and the long COVID, which are new direct enhanced services for which practices must engage and direct patients appropriately who need it. All of this aligns to the overall CCG monitoring and performance across the whole system, so the acute hospitals and all services, and it kind of fills that gap from a general practice perspective. What I've provided, just to round this off, is appointment data. So there's some national pictures around the number of GP appointments in the system, and this is a national picture, and the second slide for the graphs is the Northumberland. So you can see if I switch between those two, they mirror one another in the curves and the peaks as to the numbers of patients accessing appointments. Following on from there, we have the types of appointments. I do apologise, you've got these in your packs, they aren't easy to see, there's a lot of information there, but what that first slide shows is the national picture in April 2020, and if you look at the two circles in the centre, it shows that 48% of patients accessed appointments via telephone and 47% were face-to-face. In April 2021, the face-to-face was a higher proportion at 55% and telephone 41%. And then what I've done is just added the Northumberland pictures to that, so you can see on these graphs that the Northumberland proportions of face-to-face and telephone, so it's slightly greater from a proportionate perspective for face-to-face in Northumberland. Now, there are lots of sources of data because the input and the capture of data of general practice appointments isn't standardised. That's the national move currently, to make sure that we can look at the appointments offered and how it's being utilised and how patients are accessing care. But again, through the conversations we're having with general practice, it's about making sure that everybody who needs a clinically appropriate face-to-face appointment is offered. And those people who can use digital medium are able to do so. And we have seen that with its pros and cons. So digitally, a lot more people can go online, they can just put a request in, and 2 days later, they get a response via a text message. That is great for some, it's not great for others. Telephone systems, websites, all of those things are part of the review, which we need to maintain and keep a view on. So that's a very just quick summary, and I'm willing to take any questions from that summary, Chair.
Thank you very much. Very interesting. I have Councillor Dodd, then Councillor Bowman, then Councillor Hunter.
I think just on personal experience on the GP surgery and mother-in-law, other people, etc., wife, that getting a face-to-face isn't as simple as what people seem to think, and that, you know, the new way of working is going to be different. Things have got better in some cases and probably a lot worse in others. So, I mean, for example, at one time, if you needed a hospital appointment, you had to go to your GP first. Now, some things I see is you can just walk straight into a hospital and get the necessary X-ray, stroke, whatever. Or, you know, the service that I can't recall in my head what it was, but it was something I was told you can just walk straight in, which is great. Because sometimes, you know, you ring up your GP and they say, what date can you make next month? Well, you're ill now. You're not ill in 3 weeks' time or whatever. You know, that is a problem that needs addressing. But there is some good comes out of this, as in a lot of things have been stripped away. But it does seem that the face-to-face has become, it was a hard ask before the pandemic, and it's become even harder. And I think that is where the vulnerable feel it. That's just a comment, Chair.
Yep. Thank you. Councillor Bowman, don't forget to put your mic on.
Thank you. I just want to ask a question about the access programme that's coming next year. I got residents who complain that they cannot get access to their doctor face-to-face or by communications that are digital. And the thing is that I also have a lot of residents who go out to work and they can't make appointments to the doctors in the evenings, and there's nothing at weekends. So to hear about a 7-day service and it's 8 to 8 might be a good thing, but we've just already heard about the digital access to it, how people are taking that up. Will it be a better service? Will they be able to get access to their doctor? Will they be able to get the advice that they need? And obviously the health care that needs to come on the back of that. That is the question. I've known many residents, including myself, who've gone off to work and were being ill for days and were not being able to get an appointment until weeks ahead. And by that time you recovered, but you know, you've suffered for a long time, and the service is not wonderful before the pandemic, and it's certainly it looks promising for the future. Is it going to be that absolute, let's say, golden egg, as it were? Are we going to see a complete change in the service in the future?
Are you able to answer that, Pam, at all?
I don't think we'll see a complete change. I think what we're trying to do is make those improvements on the service pre-pandemic anyway. I think it was always challenging that we've seen the demand on general practice increase multiple, and I think that they are struggling to meet the demands on them. I think the digital opportunities for access have seen multiple more patients being able to access, and we're just trying to manage at the moment with practices. With the digital and online access, people are booking over a weekend when they become ill, and then the practices are picking up in the morning. We are working with our out-of-hours providers and the local hospitals, like you mentioned as well, about walking into one of the hospital hubs and sites to make sure we can consolidate the options and opportunities for people to be seen and have a kind of one-stop shop. But ultimately, for the continuity of care, that GP record is pivotal. And we do strive, which is part of the engagement with patients, to really understand the proportionate needs of that face-to-face, sharing the message about how important it is that is where it's clinically appropriate, they will be offered a face-to-face appointment. However, there are other alternatives. I'm not saying this is an easy challenge. We do hope these changes always bring improvements. I think the pandemic has just put an additional perspective on that, which we're working through at this time. So we will keep talking to you, we will keep engaging, and yeah, I don't want to make any promises at this point in time.
Okay, is that all right, Les?
Thank you, Chair.
Excellent. I've got Councillor Hunter, Councillor Hill, Councillor Nesbitt.
Thank you, Chair. It's a very similar question as to the first two speakers. It's not always easy to get face-to-face. It's often recommended as digital. Do it via email, you know, send in pictures, you know, and phone conversations. Yes, some things can be done that. Digitally, it might work for some people, the younger generation that's working at a time that suits, but the older general public is not so internet savvy as some of the rest of us, as well as learning disabilities. And again, if you can't get appointments that way, and it seems to still struggle to get face-to-face appointments, people are then choosing to go to local hospitals, which is putting more pressure on the hospitals. So I think there needs to be, if it works for some people there, but all the options needs to be on the table. And I think that's where we're falling down at the minute, as you're still struggling. You'll phone up, no, we can't get appointments for a few weeks. You know, try elsewhere.
Okay, thanks for that. Councillor Hill, then Councillor Nesbitt.
Thank you. I mean, just to quickly add to what's been said, I've said it time and time again, that residents' experiences when they're trying to book a GP appointment is just, and actually can be quite dangerous, because obviously there's certain people that do need to get a GP appointment, stereotypical, but typically a man, it's not just men, but you know, the stereotype of something that they're worried about, but they put to the back of the mind, and it can be dangerous if it's not seen to, and it's just not a smooth, easy, sensible process for booking appointments at all. My question, I was thinking of raising it under urgent business, but it does sort of tie into this, although I know it's under NEAS. But this morning I heard that the paramedic service, which has been providing valuable assistance to GPs in Berwick and presumably elsewhere, but I know about Berwick, and this was extended to April. And I've heard this morning that that's not going to be extended. Don't know if you know anything about that, but that obviously, because the feedback from that, and Isabel's nodding, should have heard as well, it's been excellent and really valuable support, and that would be a really, really disappointing if that rumour, well-founded rumour, that it's ending in April is true.
Are we able to come back with that at all?
I can come back on that, because just recently we are still discussing the Berwick pilot, so there's no decision being made. There was a meeting with the ambulance service and the commissioners of the ambulance service, and also the general practice element in recent weeks, so that hasn't been decided. The plan is to extend up to March at this time, because that is the only financial envelope we've got to work on at this point in time as a clinical commissioning group, but the conversations about the future are underway and there's been nothing decided at this point. What I would note is, make a point of note, is obviously primary care networks have the ability to employ paramedics directly, which is a new dynamic to the arrangement. So we're just working with the network at the minute to see what options we've got to maintain those services going forward in the future. I don't think anyone would deny there has been a benefit. I think it's just that long-term focus on emergency response in the Berwick area and balancing that with the benefits from a primary care contact perspective. It just needs to be worked through a little bit more, but nothing definitive as yet, decision made.
Just
Okay,
to
thanks for that.
re-emphasise the feedback from residents, and you know, residents like, and particularly in the health sector, you know, there can be, and sometimes unreasonably, a negativity, but the feedback, and Isabel's nodding again as well, the feedback from that service and the individual param has been fantastic. So please feed that back.
Well, I'm sure that'll be in the forefront of the mind, Councillor Hill. Councillor Nesbitt, you need to put your microphone on.
Mine's just about accessing the doctors again. I think I've brought this up in the past, Pam. One of them is, you phone up at 8 o'clock in the morning, you can't get an answer, it's an engaged tone. You phone up again at 10 past 8, still an engaged tone. 20 past 8, you will get an answer, but you're to be told you're 10th in the queue. And within minutes after that, the answer, to be told, please call again tomorrow because we're full for today. Or if you need a triage, then you can get the triage. You've got a lot of elderly patients. I've got a lot in my ward that struggle with this, and I just think we need to be looking at that system, because I think it's totally wrong for older people. They're not going to doctors. They're not phoning them up now because they can't get through. So these people are getting neglected. Okay, thanks for that.
Okay, thank you. I'm sure Pam, if you want to come back.
Yeah, I think we did a lot of work in Blythe and I supported Councillor Nesbitt with some understanding and some engagement with the public in Blythe at a point in time when we had some changes in practices. As with all councillors, you know, we are willing as a CCG to try and facilitate, and I think with some specific issues we can help facilitate with the practices. And I know the practice you're talking about, I'm willing to work with Councillor Nesbitt just to facilitate a conversation with the patient participation group with that practice, or just directly with the practice and Councillor Nesbitt. So I think if there are some challenges specifically, we do just need to work and see if we can find some solutions to overcome.
That's great. Thanks, Pam.
Okay, thank you. And there's no one else indicating to speak, so thanks for that, Pam. It was very interesting, but I think you can hear from the comments that all of us are concerned about actually being able to see a doctor. Okay, thank you very much for that. The next thing on the agenda is, if you excuse me a second, we are now at 7, which is Complaints Annual Report 2020-2021. We are concerned with the first part, which is the social care aspect of this. So we're not going to be taking any questions about the children's social care aspect of this because it's not in the purview of this committee. I think that's right.
Yes, it is.
Okay.
Yes,
So,
it is. We'll just
if
focus
we
on the
can-
adults, sorry.
That's all right. So if we want to just, I've lost track of who's doing what, so I suppose it'll be you.
I will give a brief just context, and then I will hand over to James, who has the level of detail that will be needed.
Excellent. I knew it was something like that. Thanks.
So this is an annual report that is provided both to this scrutiny committee and to the, as you rightly point out, Chair, to the Children's Scrutiny Committee, and it covers the numbers of complaints and issues that have been raised both formally and informally, and also talks a little bit about the LGO or the LGSCO involvement with the local authority. So I'll hand over to James, who will provide you or take you through the level of detail in relation to the numbers, etc.
Thank you very much, Kath. My name's James Hillary, the Adult Social Care Complaints Manager. I don't know whether people prefer me to be at the front or whether they want something on the screen there. I don't know.
I think we are happy to take this however you're more comfortable with. If you want to come and do it from where up here, that's absolutely fine, or stay where you are, whichever you're comfortable with.
I'm happy to talk to my copy here if people have their own
that's
copy.
absolutely fine.
Yeah, smashing. So yeah, there's the as Kath said, it's the complaints annual report for the 2021, which is just essentially, I suppose it covers all the feedback that we received as a complaints team over that financial year, both the good feedback as well as the bad feedback. And I'd also want to say that we welcome all feedback, and no feedback's bad of itself. The information we get from people who use our services, or their families or their carers, will tell us something about that service, whether it's, you know, whether we've been doing something well and we should keep doing it, or whether we've done something wrong, or whether something's not working particularly well and we need to do something about it. So in terms of the report itself, obviously, part one is the adult social care, and we have some data around complaints that we've received over that year. So we've received 44 complaints over 2021, which is slightly lower than the previous year. We receive, I put a little bit of data in there about Durham as a sort of a comparable local authority. So we do receive less complaints than Durham, although we have a slightly higher proportion of complaints per thousand. We've responded to 41 complaints over that year, and in terms of the outcomes, we've upheld 8 of those, and not upheld 14, and partly upheld 19. I've also put some proportions and percentages in there just to give a notion, because sometimes numbers of themselves can just sort of be a little bit difficult to interpret. In terms of the areas that get the complaints, there's a table on page 6, and as you can see, care management at the top would, I suppose, has historically always had most complaints, which is to be expected in terms of the volume of work. I think the other thing I'd say about complaints, generally speaking, is that we have comparatively low numbers, particularly in the context of the work that's carried out by adult social care across Northumberland. Page 7 has a breakdown of some broad categories that we use to look at what kind of themes or subject areas that a particular complaint might be placed under. And as you can see, the higher numbers tend to be in the standard of service provision, communication information, and a disagreement with decisions. The next bit has a little bit on CHC complaints, because we have an arrangement with the CCG to look at those complaints that we might receive that are funded by the CCG. Their numbers are remarkably low and have been remarkably low for, well, historically. So I don't think I'll dive into those particularly, but I think the next section, which is around learning, I think is slightly more important. There's a table on page 10 which relates to the key themes and the general kind of responses that you might find with an individual complaint. And I've also put in that section a number of thumbnail summaries to give an idea about the range of complaints that we get, and also to give an indication about the kinds of things we try to, the ways in which we endeavour to resolve those issues. As Kath mentioned, we do get contact from the local government and social care ombudsman. They are, I think, the last step in the complaints process, and there's some data on that in the third part. Over 2021, we received 6 ombudsman decisions. I've also put in the health service ombudsman because they would be the ombudsman responsible for CCG complaints, but we've had none from them. And I've also put in a line for the joint team, which is where a complaint might cross over both adult social care and health. So they have a specialist team that works between both ombudsmen to look at those kind of complaints. I think by and large, when the ombudsman looks at the complaint and they give us an outcome, by and large, I think we do. I think we've already, I suppose, acknowledged to the complainant previously where we may have gone wrong, and quite often the ombudsman will, even though they might uphold the complaint, they might in many cases just be reflecting back to us what it is that we've got wrong and we've already acknowledged back to the complainant. And again, in terms of some comparative data with Durham, we do get markedly less ombudsman inquiries and investigations than they do. I'm hoping that's a positive thing, but now that I've said it out loud, I'm sure it'll come back and bite me. And the last couple of sections, we've got a section on numbers of inquiries, which I suppose people who contact the complaints team who might have something to tell us, or they're a little bit unhappy about something, and they're not people who necessarily want their issues dealt with formally, but they're still looking for some sort of resolution or some sort of action to put things right. So I've given, as I said, the report a little some data on those. We also receive a number of compliments. And the one thing that I would point out in terms of compliments, particularly from our independently contracted providers, which will be like residential care homes and domiciliary providers, their compliments have markedly increased over 2021. They provide this information to the complaints team quarterly, And it does appear that I think that the people of Northumberland have, I suppose, felt more inclined this past year to I suppose, make a point of saying thank you to the providers, particularly in what might be described as exceptionally difficult times. So that's something, as I said, that I just wanted to sort of to highlight. And there's the last few sections. We've got a little bit on advocacy for those people that might benefit from advocacy, a few little conclusions, and then I suppose right at the end there's a section which gives, I suppose, a paradigm or a process that we would follow when we try to resolve complaints that people might make to us.
Lovely, thank you very much. That's very interesting. You've stunned everybody into silence. Councillor Hill, I knew I could rely on you.
Thank you. Yeah, it was just sort of a point and a question. It doesn't surprise me that some of the complaints are surrounding explanation or around costs, care packages and so on. I've had this quite a lot with residents who have had quite upsetting situations where they've had a shock at the bill that's come in, and a bill that's come in which has meant that their deceased parent, usually they've had to sell their house to cover the cost. So I definitely think, I don't know if it's obviously a sensitive issue, it's a British thing, not wanting to talk about money clearly, but some people have had really nasty shocks at the costs around care. And this is reflected, not surprisingly, some of the complaints. Has this been picked up on? Are staff being given clear training about explaining? I mean, some of these people aren't necessarily experienced or trained in financial matters, but it's obviously really important. And maybe another option, getting other people in that his job is to explain things in a clear, simple way regarding the finances, because I think that is an important area.
I think Kath's going to pick that up.
So I think it's a really relevant point that you've raised, Councillor Hill. I think we always are striving to ensure that the messages that our staff give out to residents and families and carers are very clear and very concise in terms of an understanding of the charges. The charges process is extraordinarily complex, and I wouldn't profess to be able to be an expert in that area at all. There are times when situations have been explained, but families don't understand, and I think we need to be better at picking up when we don't think that families fully understand what the issues are, rather than necessarily them not having it explained to them in the first place. I think we need to understand that these are complex for everybody, and that families, when they are in a situation of making decisions about what they want to happen for their nearest and their dearest, they're not always listening to everything that's going on around them. That's not to say that it's just the residents' fault for not listening. I don't want to make that differentiation, but I think we are always working with our staff to try and make sure that there is a full understanding, or that they offer relatives a full understanding of what the implications might be.
Is that satisfactory?
Yeah, I think
Okay, Councillor Hill. Sorry, Councillor Hunter.
I think just picking up from what Councillor Hill's saying as well, is it's what they get for the money. And I think it's as the clear sort of information gets left with the residents and the family, so they can read it at their leisure to say, yes, if I'm paying X and Y, I can get this. And then if there's not understanding what's actually written down, because they're in vulnerable situations, it's that there's a contact, a local contact that they can go back to and say, am I reading this right? That I can get X, but if I want Y, it's either not available or it'll be an extra cost.
Okay, Councillor Dodd.
Yeah, my experience of a lot of this is generally, after reading some of the reports in here, it's an elderly patient and then an agitated offspring that gets, or whatever, or someone who doesn't get what they want out of a system. And they always use, as councillors and some new councillors on here, you'll all hear the, I'm going to go to the press. And when you see an article in a newspaper, you're probably only reading one side of a story that the press, you know, want to put because it puts a council or a whatever onto the sword. So I'm always very sceptical when I see things in the press of a complaint that has gone awry, because generally means one side hasn't got exactly what they wanted out of something. So I'm very sceptical, and I'm pleased that our figures are low, and long may it continue, but we all know, and we all get them, and anybody new, you're going to get them, the people who just won't accept whatever decision is being made, and they'll go to any length to change that decision. Thank you.
Yeah, I understand that. I've just got a couple of questions then. First of all, I know this is just me with my picky head on, but you've got X's in some of the columns, which I take it means 0, but you've got 0 in others, which kind of made me think the X meant something else. So could we do one or the other next time?
Noted. Thank you for that. Yes.
And the trend, that's all, I understand what a trend is, but some indication whether that is good or bad would have been helpful. So in some cases, I obviously can't find one now, I'm looking, but down is good. And then in other cases, down is bad. So if I could have some indication somewhere that things are improving or they're getting worse, because they say a lesser figure sometimes is good and sometimes it's bad. But overall, I think even when you look across the 3 years, they're all of the figures are kind of within an acceptable envelope as far as I'm concerned. There's not a massive, you know, it may be up or down, but it's not massively up or down. And when you think, you know, we deliver millions of interventions every year, must be. I mean, we visit thousands of people, you know, many times a day in some cases. So I think, you know, you've got a system in place that's recording people's complaints, and that's right and proper because we need to keep an eye on it. But all in all, I think it's remarkable that you've only got this few, to be honest. So well done, and whatever it is you're doing, keep doing it. But the other thing I would say about the report, if we're not going to deal with some of it, perhaps it would be best to have 2 reports rather than one, have an adult one and a children's one. I don't know whether that's...
Yeah, I absolutely agree. I've made a note and we'll discuss with the manager of the service for next time.
So if anyone else has any other comment other than that, then we shall move on. The next thing is the reports of the scrutiny officer, Health and Wellbeing Overview and Scrutiny Work Programme. Chris, do you want to say anything about this? Or
You know, it's an opportunity for members to offer up anything that they want to include on the work programme. I've spoke to the Trust about end of life following Councillor Bowman's suggestion at a meeting, not the last one, the one before I think, and we'll likely have something come at the end of the year, maybe starting next year once the consultations are finished. But if there's anything else members wish to add to the work programme, just contact either
Councillor Hunter.
Yes, following on from what Councillor Hill said, I think if we could have the paramedics NES from an update from the Berwick Hospital as to what value it's been, and again before it comes to near the end of March, so that it's maybe too close that we maybe end up losing it.
Okay, is that agreed? Everybody happy with that? It looks as though we are. Urgent business, haven't been informed of any, and the date of the next meeting is Tuesday the 5th of October at, it's got 10 AM on here, but it isn't. It's 1. Don't do that to me. So, and the venue is to be confirmed. So we might have a call in, we might have anything could have happened by then. So we shall look forward to finding out where the venue is. Anyway, thanks for your... Yes, sir, sorry. Could you just put your microphone on?
David Thompson from Health Watch. Could I just ask for some support, please? Because Health Watch Northumberland, it's the independent voice of the public and so on. And like everywhere else in the world, has had great difficulty in engaging with the public. But what they're going to do is they're going to try from September to have a hear-to-hear campaign where they go out to 5 different parts of the county to listen to what people have to say, about health and care services. It has been publicised, but I've been asked by Derry Nugent, the project coordinator of Health Watch Northumberland, to make available somehow safely some cards with the dates on, some background information, and also perhaps for some councillors, some posters which might be displayed just to let people know that the service is available for them to contact Health Watch face to face to pass on any issues which they like to raise, which we would then sort of compile, analyse and pass on to the providers and commissioners. So sorry to sort of...
That's all right. We can promote that, get somebody, I'm sure our Facebook page can promote it for you and all sorts of stuff like that.
I don't know how we can pass these around safely and securely and hygienically with the pandemic and so on. I've got a glove. So it's just the early days in this new way to try to contact people.
Yeah.
So if anyone, any council from where? Blythe, Morpeth, Cramlington, Haltwhistle, there's some posters there, and for anyone, some little cards which sort of publicise this. So
Excellent.
sorry to interrupt, but I was asked to pass on this information.
Yeah,
Thank you.
heard and understood. If you feel as though you can take a card before you go, please do. And if Chris, can we see if we can get something on our Facebook page and that sort of thing? Okay, excellent.
Thank you.
So no trouble at all. Thank you very much. Look forward to seeing you all in October.